Okay, welcome everybody. Um, if you're here to hear about shifting the dial on children's health outcomes, then you're absolutely in the right place. My name's Andrew Laird. I'm the Chief Executive of Mutual Ventures. We're a consultancy that focuses on public services. One of our specialist areas is children's services, and we do a lot of work with the Department for Education on children's social care, but also supporting system in place leaders to think about how they can improve health and well-being outcomes for children and young people. We also work more broadly on supporting areas to explore and implement really great place leadership and collaboration across organizations, which, as we will discuss, is critical for this topic. So shifting the dial on children's health outcomes is the second of our prioritizing public services campaign, following our first theme of radical place leadership last month. And you can catch up on all of that on our website or LinkedIn feed. Today, I am absolutely thrilled to be joined by Professor Kate Ardern, the former Director of Public Health at Wigan Council. And if you were in Greater Manchester around the pandemic, you would have heard from Kate a lot, as she was the Greater Manchester Public Health Lead. Also joined by Tom Reardon, who is the Chief Exec of Leeds City Council, and Jill Burns, who is the Children's Services Director for Essex and Kent at the North East London Foundation Trust. So I'm really thrilled that you've all taken the time to join us. In terms of housekeeping, this is being recorded, and I will send the link afterwards, which you should feel free to share. You can also post any questions you have using the Q&A function below. But before we get into all that, let me first try and set the scene. And this is partly drawn from a discussion paper that we produced recently, and which I will also include in the follow-up email. So children's health is clearly an area of great concern, and there have been a lot of other excellent but often terrifying reports published recently from, among others, the Association of Directors of Children's Services and Sir Michael Marmot's Institute for Health Equity have both produced reports recently which lay out the really terrifying state we are in, really, with regards to children's health. And the messages are pretty consistent. So some example statistics: 30% of children living in the most deprived areas are obese. 1 in 4 older young people had a probable mental health condition in 22. That's up from 1 in 10 in 2017. That's a huge increase. Tooth decay is the most common reason that 5 to 9-year-olds are admitted to hospital. Now, it's increasingly recognized that social factors play a huge role in determining children's health, and living in poverty being the clearest indicator of that. And if we look at that, 4.2 million children, that's 1 in 4, live in poverty. 48% of children from global majority groups live in poverty. And since 2017, the number of children living in destitution has risen threefold. Now, of course, this is not just awful for the health and well-being of children. It comes with a 39.5 billion price tag, according to the Child Poverty Action Group, and this includes a huge increase in the cost of healthcare associated with poverty. However, despite its importance, children's health is not always top of the agenda around health inequalities. In fact, in its formal response to the independent Hewitt review, that the government mentioned children just once. And elsewhere in the 22-23 NHS priorities and operational planning guidance, they're also very light on detail in terms of children. And this point was not missed by NHS Confed, which criticised the document, claiming that it could have gone further, particularly in relation to the backlog of care in children's community health. However, integrated care systems and integrated care boards, at the very least, have the ambition to tackle children's health. We did some analysis of integrated care board plans, and some of the key themes kept emerging. So there's broadly a focus on giving every child the best start in life. There's a focus on addressing long-term conditions and a focus on improving children's mental health. But the simple fact is that the NHS alone cannot hope to achieve this without working in partnership with others, because so many of the wider determinants of health sit outside the traditional boundaries of healthcare. So our discussion paper recognizes that making progress requires collaboration and partnership across the range of organizations working in social welfare, housing, the environment, and education, as well as healthcare. And to try and help with this, we set out a framework for better collaboration around children's health. Now, this is not rocket science, but that doesn't mean that these behaviors and actions are being widely adopted. So what does this framework look like? And I will send the link to this full report in the same email as the recording. So number one is that leadership is firmly on the same page, and that's place leadership. So everyone agrees that on what they're trying to achieve, and local leaders really must create an environment which enables and encourages collaboration. And there's a big link here to our previous webinar on radical place leadership. So if you're very interested in that, I suggest you take a look at that too. It's important to identify and engage with the right stakeholders. So when considering the wider determinants of children's health, it will become obvious the huge array of stakeholders who have the ability to impact that. So what are you going to do about that? At the minute, this must include key council services and pivotal local third sector organisations, many of whom feel quite isolated and underappreciated, certainly the ones I've been speaking to. The next item is on priorities. So you've got to decide priorities. If everything is prioritized, then nothing will be prioritized. So the devolution to integrated care boards and to places in neighborhoods make the task of prioritizing more achievable. And I think there's really important links to local democracy here, and maybe Tom can speak to that a little bit as well. Shared and accessible data is important. If local partners don't know what the problems are and what the key issues that a place has, then how can they possibly respond to them? And of course, the ultimate aim is then shared records to enable the seamless delivery of services. And the final point is around delivery structures and measuring impact. So the change that I think we're going to be talking about today is as much a cultural shift as it is about exactly how things are organized. But you still need to have a delivery structure which enables people to get on and provide the help that they can see is needed. So that's what I was going to say by way of introduction. Sorry, I rattled through that, but there's more detail within our discussion paper, and really today is about hearing from our fantastic guests. So I am going to invite Kate to come in first. Kate, it's great to see you again. This is not your first time on a Mutual Ventures webinar, so it's really good to see you, and I'd love to get your perspectives on the challenges we face with regards to children's health.
Thanks, Andrew. And I take it I've got about 10 minutes. Is that correct? Yeah, thank you. Good afternoon, everyone. And it's a delight to be on with Jill and Tom in particular. I'm going to slightly add to Andrew's gloom, if I may, and I wouldn't be a public health professional if I didn't add a few other statistics. But it's also a pointer to perhaps some areas where we might concentrate on some early wins and actions. So I'm going to come to something that's very dear to my heart, children's IM and VAC. The decline in our routine vaccination programme uptake is absolutely terrifying to a public health physician. We're looking at diphtheria, pertussis, tetanus and polio uptake at 92.6% for children aged 2, 91.8% at age 1. This is from the Nuffield Trust recent update of the 15th of February this year. MMR at 89.3%. We know in certain parts of England, in the West Midlands, in parts of London, which I'm sure Jill will be well aware of, the uptake is as low as 70%. And we've got a major measles problem in terms of outbreaks happening. And then for something you'd expect really high uptake, Hib and meningitis C uptake, it's at 88.7%. Now, these are illnesses that kill or cause serious lifetime consequences. I'm actually a victim of the last big measles outbreak in the 1960s, and it has affected my health lifelong. but it's also one of the reasons I'm a public health physician as well. Prevention, an early lesson in prevention is better than cure. This is something that requires, and Tom will smile because we had this experience with the COVID vaccine. It's about local intelligence, local partnerships, local relationships. If we're going to tackle this, it cannot be done in Whitehall. It has to be done in that investment in time and building relationships and trust through our communities, through the VCSE sector, and very importantly, through our frontline staff. But an early win if we aim to turn that around. And Andrew, I would say that's something that a local partnership can, a place-based approach, and from our experience with COVID, we know it works, is actually really important. Plus, actually doing away with some of the stupid bureaucracy we have in some of the central procurement. For example, in Wigan, we wanted to deploy all of the vaccination programmes through schools. NHS bureaucracy said, no, the vaccine has to go to individual practices. It can't go to a lead practice that then goes and deploys it out in schools. We need to be working on that, and we managed to have some workarounds, but it was down to local ingenuity to make that happen, and maybe that's something we should be advocating for. I'll move on to another topic that's also very dear to my heart, and you actually mentioned it, oral health. I think we often forget with children's teeth, not only is it a problem in terms of the issue of elective admissions for children, which entirely preventable, but we're having children not being able to access their routine dental appointments, which they should be having from age 1. And of course, decayed, missing and filled teeth statistics at age 5 actually are a precursor for future heart disease problems in middle age. People forget that. Your teeth are very important when it comes to your overall general health. So we're storing up future problems for kids, not just in terms of the immediate problem that hits us. We should be tackling that. And it's either, we can go down the long route of things like fluoridation, but actually things like fluoridated milk schemes, brushing schemes, which I know obviously Labour is advocating, very important, cheap, effective, and actually would help to make a visible difference. Can we be doing that at a local partnership? So I'm raising some problems, but also maybe some solutions as well. One of the other areas that I'd pick up on that you did was obesity, and again, I think there's some really active considerations we should be doing at a local level, linking in, for example, to great initiatives like the Daily Mile, like Sport England's Get Active and United in Movement programs, really important things we can do and link into locally without waiting for government action. But also, of course, things like supplementary planning guidance. If you've seen the report this week, look from Cambridge University, looking at the clustering and preponderance of junk food outlets in our poorer communities, then what do we do about that? Now, that's a real challenge, given, we're also trying to improve business rate uptake in local government, but it's almost having a triple whammy on those communities, and it's ingraining obesity in children at a much younger age. When I graduated from med school in 1986, you never saw type 2 diabetes in anyone under the age of 50. We're now seeing type 2 diabetes quite regularly in children as young as 10. Now, if you think about that, and again, the consequences of other diabetic complications, you're going to be getting those at a much younger age. And I guess the challenge there is we need to be preventing that. So how do we make sure that our children are not experiencing those kind of challenges? We've already got a cohort that are going through with that. And then I guess lastly from me, I think another major priority, we always come back to the sense of the poverty and insecurity. So, the challenge is, as you outlined in the excellent report about the impact of child poverty, I'd point to another great example of why it doesn't have to be like this. And if you look at the Scottish child payment, the £25 per week for every child under 16 for eligible households, that has recently been assessed by Nesta to have an impact of reducing the poverty rates by 5%. It's a significant difference on top of the UK child benefit for low-income households. Now, could we be looking or advocating for something like that? England actually copying Scotland. I'd also suggest copying Wales in the sense of having a Future Generations Act. So I guess my sign-off is, yes, there's some really dreadful challenges that we face, and those are just a few added to the ones you've identified, but there are some pockets of good practice, some things we should be looking to put in place, and certainly some of the work I'm doing currently with Lord Filkin and others on the follow-up to a Covenant for Health would put children's action front and centre for the first 100 days and first year of a new government. Thank you.
Thank you, Kate. Just one follow-up question for me. So Wigan has a very well-deserved reputation for collaboration and place leadership. Have you any practical hints and tips as to how you did things in Wigan in terms to try and shift the dial on some of these things? Like, what sort of relationships did you have in place? What sort of mechanisms did you have in place?
Two things, Andrew. Firstly, to recognise that your place and your primary care networks need to recognise the geography of place. So we aligned our primary care networks with our existing neighbourhood structure, which is what local people recognise. And we built the services around the two registered populations in place: schools and GPs. How seldom do they talk to each other? And yet they hold the key in terms of that sharing of data and having daily huddles together.
Yeah.
And secondly, bringing children and young people into the discussion themselves. We often, as adults, disregard their voice. Oh, it's very tokenistic, and I'm sure Jill will have more to say about this. But actually, the youngest person who's addressed Wigan Council is a girl called Ember, and she was 5. And she knew more about recycling than any adult in the room did. And it's actually not sort of seeing children as people we do things to, but people who we co-create with. So introducing the Royal Society of Public Health's Young Health movement and really utilising that across our schools and young people. All, for example, young apprentices in Wigan Council have the opportunity to do the Young Health Champions training, and boy, do they do it, and boy, do they use it. I don't care where they, I didn't care where they worked in the council, but actually someone who's working in finance, who's done their Young Health Champions training, is actually a better advocate for public health than the Director of Public Health sometimes.
Lovely, Kate. Thank you so much. Tom, I'd like to come to you now. I know you're doing some exciting work in this area in Leeds.
Thanks, Andrew. Yeah, great to hear from Kate. And I had the pleasure of doing a peer review for Kate and Donna at the time for Wigan, and they've done some fantastic stuff there with the Wigan deal and everything. Leeds is very similar, I would say, in our outlook to what Kate has described. And my main, I think, message on this in terms of making a difference is that culture is everything. It trumps strategy and process and thresholds and everything else, especially when you're in a big place like we have in Leeds. 812,000 population, 170,000 children, a third of whom live in the most deprived parts of our city, and the the challenges that you described, Andrew, and that Kate remarked upon are absolutely here in Leeds. You know, poverty is increasing. The challenges of making sure that children grow up healthy and well fed and having dental appointments and having a happy and healthy life with places to play and, you know, communities they feel part of is as big a challenge as it's ever been, I think, to achieve at the moment. And the way we try and do it in Leeds is very much that, you know, restorative, if you like, way of working that Kate described, doing things with people, with families, rather than doing things to them in a you know, traditional hierarchical way, or for them in a paternalistic way. We have family group conferencing in Leeds. We have where, you know, families try and sort their own problems out rather than we do it for them. We're there to enable them to succeed, and that's the way that we try and work. We have our plan to sort of put some examples behind what I'm talking about is based on 12 wishes of children in the city, including that them getting support for their mental health and well-being. This is a huge issue. Our Director of Public Health, Victoria, did a report this year that showed that problems in children and mental health have gone up by a third this year after the pandemic, with the hangover from the pandemic. Huge issue for all of us, and it's rare you'll meet somebody who doesn't know a family or friend who is in that situation, having difficulty with anxiety or you know, eating problems or other issues as they're growing up. Safe places to play. We have a play champion now in the city that we're investing in. We very much focus on poverty, and we very much focus on Leeds is twice the geography of Birmingham. It's 5 times the geography of Manchester City Council's area, so it's a very big area. And so we have everything from the leafy suburbs right the way through to the inner city and everything in between. So if you don't take that place-based approach and that neighbourhood-based approach, you fail. So we have succeeded, I think, in terms of the work we've tried to do. And, you know, it's always a challenge, but on things like healthy weight, for example, where we've done a lot of work to basically keep as much of the Sure Start system as we possibly could through austerity. So many parts of Leeds still have children's centres, and out of there we provide healthy weight advice and a plan for families and for children as part of our universal service. So it isn't targeting particular children who are a problem. It's actually doing it very much in a way that helps parents think about, you know, their cooking and, you know, what they buy for their children, and tries to link into the poverty agenda and trying to make the best out of the money that people have available to them. And also the Henry programme that I'm sure, you know, you'll have heard of, which is a very successful scheme that we've been doing. And before the pandemic, we'd actually got our healthy weight down well below the national average. It's gone up because of the pandemic, but it is now coming down again because of that very integrated way that we try and work in the city. We call it radical collaboration. You know, it's about how you almost need a culture where your default mode is that the NHS, you know, the GP practices work with the district nurses, with the you know, the mental health practitioners, the social workers, the children's care workers, you know. And so, for example, on our Best Start work in the city, about the first 1,001 days, we have you know, a highly integrated plan with an integrated nursing service, infant mental health service, children's centre colleagues, library colleagues, you know, acute trust, GP leisure service, all sort of not absolute experts in it, but with a knowledge of, you know, the basics, and also a knowledge of where to signpost families. That really is so important, so that you're not relying on the, you know, the specialist provision that is, because of the acuity of a lot of you know, the situations that we find many families in, that is never going to be available to the vast majority of the population. So finding a way to mainstream some of these, that basic, support and advice and and signposting into the way that we work at that neighbourhood based level. That front line, if you like, is absolutely crucial to to what we do in Leeds and what we're trying to achieve. We've been outstanding rated twice on children's social care, which is pretty unheard of for a big city, and we've just got that for our young people, skills and employment for our young people coming out of school, which we're really proud of. We do lots of work to tailor the mainstream support we have. So we do big careers events for young people, adolescents coming and their families, and we asked our kids with special educational needs what we should do differently, and they said, we'll do an event for us at the arena. So we did. We had 3,000 people there, very different event to the one that we ran for the mainstream, if you like. And it was just, if you need your faith repairing in human nature, then you need to go to one of these events where, families are meeting all these employers who really want to help and, respond to the new, challenges that some people have in their lives. So yeah, we I could talk lots more, but I'll maybe leave it for the discussion. But I just wanted to finish with another thing that always will make people smile. So we have symbolism's quite important as well. And in Leeds, we have a children's mayor, and we've had one for the last 12 years. And every year, the schools take part in a competition for the 10-year-olds to put forward a manifesto from each school. And then the children vote on. We have a panel that sifts them down, and they vote on the top 12. And every year we elect a children's mayor in Leeds, our full council of all the 99 councillors. And they always get a standing ovation. It's the best day of the year, with the greatest respect to my councillors who make brilliant speeches all year, of course. This is Mohammed, who's our children's mayor this year. And his manifesto is about tackling climate change, and he goes around. It's like a mini me Lord Mayor who goes around the city and opens things, and it's like that way of turning this agenda from something that's niche and something that's only about the people with problems into something that's everybody's business in the city. We have 800 business ambassadors who help achieve our goal of child-friendly city that's a UN standard. So yeah, it's about hardwiring this into the way a place runs, rather than just doing the more specialist stuff, which is really important as well. So I'll leave it there. Thanks, Andrew.
Thank you so much, Tom. That was really inspiring, and just everyone, looks towards Leeds as a place where really exciting things are happening. I've just got one question before I bring in Jill. I love the idea of radical collaboration, and just that, Jill, apologies, would you mind just going on mute just sorry. I love the idea of radical collaboration, and it feels like what you've got there is a system where frontline staff can do the thing that makes sense, if that means working across service silos and things like that. And I'm just wondering, how do you achieve that from a leadership level? How do you create that enabling environment where middle managers get it and frontline staff get it and feel okay and feel like they have permission to work in that way?
Yeah, I think it takes a lot of time, and I think staff need to be confident that they're going to be backed if they do something that doesn't quite work at times, and the fear factor can often be the one that is the biggest barrier. But we try and work with a really clear ambition for the city, and that child-friendly narrative in this case, and also a very clear set of values and behaviours which are about working with people, working in partnership. We call it team leads, and that it's the expected behaviours for everybody are around that collaborative way of working, and not trying to cut other people out, sharing data wherever we can. It takes time, I would say, and you've got to almost codify what you mean by it in the
Yeah.
we have an appraisal system that I get quite obsessive about at times, where I'll make sure everybody in the organization has their appraisals on time, and that's as much about the targets they have and the bulk of their work, but also about the values and whether they're walking the talk of the behaviours as well.
Yeah.
And we sort of clarify what we mean by that at that local level.
Yeah, no, really interesting. And I just how do you how do you test whether it's working? Do you have you've got your appraisals that you mentioned there, but how do you prove to the to the staff and the other organizations who you're trying to get to work that this is worth doing from their perspective? Because one of the challenges I quite often see when I'm talking to places is that if if something if there's something that is creating benefit across the system, so sometimes organizations are quite reluctant to invest in it because they feel that most of the benefit is going elsewhere. Is there an understanding in Leeds that we'll do a bit that will help you because we know that you'll do something that will help us in the future?
Yeah, I think again that takes time, and I think that because we deal with different governance and different metrics, and you'll hear from Jill, I'm sure, sometimes the people who have to straddle councils and NHS, it's sometimes like with the money, it's like going from pounds to euros a lot of the time, and it really doesn't. The system doesn't help you to collaborate often. But I think that's why I say about culture being the most important thing, because people will work around those things if the values are right and if that leadership's come down and the strategy is clear. There are data is really important, and been able to demonstrate that. One of the things I get very, I'm very keen on is that value for money and the finances are as much a part of this as the outcomes for children, because the only way we can pay for this and keep the preventative stuff going is if we can make it work in financial terms. So value for money is one of our 5 values, and it's often something that sits to the side for people. So yeah, I think those things, and the regulators see it as well. The Ofsted reports, the CQC reports. That's where you look for whether they all hear the one city stuff when they arrive somewhere, but can you actually hear it from the practitioners on the ground? Does it work when a family is having to deal with 6 different agencies, but they're working together on the ground? And that's where you can hear it as well.
Fantastic, Tom. Thank you so much. Jill, really delighted to bring you in now. So we've heard a couple of council perspectives from Tom and Kate. Jill is from the NHS, and it'd be great to hear how your reflections on what you've heard and also how the NHS collaborates with others on children's health.
Yeah, thanks very much, Andrew. And I mean, it's, I guess, in some ways really reassuring that I'm listening to Kate and Tom, and every single thing that they're saying pretty much resonates with some of the things that we're all grappling with every day. And I have to say, some of those radical things around children's and Leeds sounds fairly amazing. So I might pick that up separately. I think I've been looking at this with a slightly different lens, but there are so many similarities for all of us. I guess for me, one of the biggest challenges at the moment is, I know Kate talked us through a lot of those physical health things, actually quite shocking as to the situation we find ourselves in. And if I was listening to some of the school nurses now, they talk to us continually when we do like webinars and things about children no longer being school ready. And some of the shocking things, not able to use a knife and fork, not able to go to the toilet. And then if I move that along into the mental health field, which is a predominant part of my portfolio, we see not as much money invested anymore in the prevention end. We know that the kind of collaboration we've had previously, whereby our social care county councils have previously invested in collaborative modelling around our mental health services, and a lot of that's being withdrawn now or reduced because of the tightening financial envelopes. And then sometimes I think that you get into a position where it all goes into the too difficult box. But actually, I think we've had some really good examples in the footprints that I work in of how we've actually tried to do some of the things that Kate and Tom have just been talking about. So I guess from a slightly more on the ground perspective, I think the things that jump out at me are we know that none of this will happen without the shared vision, really strong leadership. And I say that because Tom mentioned something there about fear in our staff. And for me, there's something about not just our staff, but us being brave. Because there are times we're having to put ourselves in a position in taking decisions and doing things differently, whether that be how we recruit people, joint posts, working at place level, making financial decisions that we wouldn't normally do. So I think there is definitely something from the kind of top of the organizational leadership structure right down about being brave and setting the tone. And then there's all those other enablers, which I think, if we're really honest, aren't quite there yet. The shared records aren't quite there yet. The links to primary care, I think Kate referred to when she was talking about the role of our primary care colleagues. And I know that they now are in a position where there's a lot of disinvestment. And I actually was at a meeting earlier on today with some of our LMC colleagues talking about, okay, what would good look like when we've got a continually reducing envelope? So some of the things that we have done in the areas that I work in, which have been, I guess, producing something much more positive, there's still a bit to go. And that's where we've worked in a provider collaborative over various elements of our delivery. So we've got some NHS England devolved provider collaboratives around the provision of our Tier 4 CAM services. We've also got devolved provider collaboratives around our eating disorder services, and that's fairly national now, looking at place-based provision, keeping people within their own footprint, and that then means you're able to work with that bigger, wider system. We also are involved very heavily within our Kent and Essex footprints with large organisational provider collaboratives, whereby, for example, the adult mental health provider, the children's mental health provider, and the children's community health provider are working together with shared vision, trying to break down those organisational boundaries and actually digging down to the nitty differently. So a really good example of that, which crosses every area issue for all of us, is the provision of diagnostic services for neurodevelopmental children. And I thought it was really lovely when Tom talked about the careers day for the special educational needs. So what we've done within our provider collaborative is think, what is our trickiest, thorniest issue that reaches across health, social care, education, some of the place-based neighbourhood teams and healthcare partnerships, and it is a really hot topic. And we've really got our staff working together, digging down into what does good look like for that children and family. We don't have all the answers. What does the family want out of this? Because very often what an NHS trust thinks a family wants and what they really want are two completely different things. And I've been very much an advocate saying that we focus so much on the diagnostics that we forget about the wider impact on the family and what support that family might need. So we've been looking at modelling across all the delivery services, trying to do things very differently, trying to look at our voluntary and community sector organisations to ultimately, and we're not quite there yet, and we've been working with mutual ventures on this, what would a good offer look like for a young person and their family? And that doesn't necessarily mean more investment. What it means is pulling together the people that are already out there that are all working in disparate groups across the piece. And for me, I guess a sad reflection on this is that I have the, if you like, privilege of going to inquests when we very sadly have suicides. And it's very interesting to listen to, particularly recently post-COVID, of the reflections of coroners when you go to a coroner's inquest. And I guess what they try to pinpoint, because you'll get a health provider going and talking about their investigations and lessons learned. You'll get social care and their lessons learned. You'll get the police coming along with their vulnerable children and missing children teams, and anyone else that happens to be involved in that family's life. And everyone talks about their own individual learning, but actually, it's that wider system learning that's the bit for me that's the key part of the jigsaw. And actually, I think the next step of that is, what does the wider system care plan, risk assessment, social health care plan look like? And that's the bit I think we've got to have the ambition to get to. I think we have got lots of mental health in schools teams contracts within our trust, and I think they're going to be a real enabler for the future. I think co-production with our children, young people, is actually key, because they've been the ones that have been really pushing us about our digital offers, because we don't have to, I think Tom referred to this, we don't have to do everything. We can provide resources and assistance across the piece and help people to do for themselves. But I think we really do need to continue to kind of keep the foot on the gas pedal, be brave, and as senior leaders be really clear about what's our vision, what's our organizational boundaries look like. Let's
Losing Jill a little bit there. Is it just me or?
go
Sorry, Jill, we've just lost your connection there a little bit.
for
Can I just check? Is that just
you
me or is it?
new ways of
I'm hearing the same
working,
as you, Andrew.
because our financial envelopes are not going to get any bigger. We've got to do something different. The little adults of the future.
Thank you very much. Thank you, Jill. That was really fascinating. Your connection was slightly wobbly there, but we heard 99% of that, and it was absolutely fantastic. Thank you. So I've just got a general question now for all of you, and it's around prioritization and missions, if you like. So some of the background for this. So Donna Hall, who's one of the Mutual Ventures non-execs, who I think you all know and listen, the viewers will probably know as well from our last webinars and from just Donna being Donna. We were talking about Mariana Mazzucato and her theory around mission-driven government, and we were thinking, how do you get organizations in a place to work together, and could we have something like mission-driven place leadership? Now, immediately you start to think that requires prioritization, and that means not prioritizing everything. Is that the way to go? Because I think, Jill, you were starting to suggest that you picked some thorny issues, I think was the way that you described it, that were impacting across organizations, and it was almost like you were saying, let's pick this and see if we can work together on this that we know is in everybody's interest, and then maybe we can go from there. So is that fair to say, Jill? And then I'll get a comment from Kate and Tom.
That's absolutely right, Andrew, because we know that, as you say, prioritization is key. We need all stakeholders bought into that. You need all those senior leaders building into it. We know that funding is not in line with demand. So rather than just cherry pick a few little low-hanging fruit, our decision was to tackle the biggest system issue, not just because it attracts
Jill, I'm afraid we're
of
losing your connection there, unfortunately.
interest.
I'm not sure if Jill can hear me. Jill, I'm just going to pause you there. Sorry, the connection is breaking down a little bit. Tom, could I get your thought on that, just around choosing priorities, the whole concept of being mission driven?
Yeah, I think we have been in Leeds actually, and I'm a great advocate of that as a way to try and get that join up between the different silos, if you like, particularly nationally. So I think mission-driven approaches are definitely something that we should be thinking about more. And I also think they're a way of getting more of a collective endeavour and feedback loop between the national and the local as well, which is a constant challenge in our country. You know, we're highly centralised. We know that, and there's a lot of, you know, good initial progress being made on devolution to the mayors in parts of the country, but actually to really get change on these sort of agendas, you've got to engage practitioners at a local level, and even the city level in our case isn't good enough. You've got to get down to that neighbourhood level to where people are interacting with families. So I think I don't have a problem particularly with the national mission approach, setting those priorities as well. You know, that's what, you know, the national government's elected to do, but being clear about what they want to happen. The big mistake we make as a country is that they then try and, from Whitehall, anticipate and define the how everywhere right across the country, and then we end up with a postcode lottery, and people don't want to give more flexibility to local areas because they fear a postcode lottery, but actually they've got one already, and it's based on poverty most of the time. So it's actually not even a lottery. You know, it's to do with how much money you've got. So yeah, I really would advocate that, and I would say you know, large parts of the country have been trying to do that. Yeah,
thank you, Tom. Kate.
Yes, to strongly agree with Tom, and I think the experience that Wigan and Greater Manchester have had is very much around that, where you are able to influence and have some control and agency. That has to be at a very local, hyper-local level. And I think that's particularly true when you are looking at a mission around giving every child the best start in life. It's that good old Dahlgren and Whitehead model, doesn't it? It starts with the individual within their family circumstances, within their neighbourhood. And it's I think it's actually quite important that a local mission is really based on that. So yeah, nationally, you know, mission-based government at a national level is great, but it needs to be, if you're going to really engage people in place, they've got to have that sense, as Tom, you said, team leads. You know, I think one of the best comments I ever heard on the Wigan deal was one of our GPs saying that he was very proud. He'd always been very proud to be a doctor, to be a GP and work for the NHS. But now, after he'd been through deal training and been through that sense of a joint mission for place, he was very proud to be a doctor, very proud to be a GP, still very proud to work for the NHS. But what he was most proud of was being a member of #Team Wigan. So I think that sense of mission brings people together in place.
Yeah, no, I think that's really powerful. And just got a comment from Jill here about it requiring shared and agreed outcomes at a system level in realistic timeframes. So I think that's important as well. Could I just dig deeper into this, because I think this is what the thinking Donna and I are doing on place leadership really revolves around: the ability for leaders in an area to agree priorities and stick to them and have good ways of measuring how it will benefit everybody and how it will benefit the place. Have you any hints or tips on how to actually go about that engagement with your fellow leaders when they are maybe under pressure from their regulator to stay in their own lane, to keep focusing on what they're meant to be focusing on, and as a place you're asking them to do something for the wider good, which seems obvious, but often the environment makes that quite difficult, particularly now when every public service organization is under pressure. If there's any hints or tips as to how to go about having those conversations at that leadership level, that would be really useful.
I mean, yeah, I think at the heart of it, it comes down to relationships, and
yeah,
I think you've got to be really clear. We live in a complex world, more complex world than we did when I was growing up, and in that complexity, all the issues that we're talking about, whether that's healthy weight and obesity, whether it's mental health issues, productivity and growth, inequality, poverty, they're not, you don't have a department of poverty and inequality or a department of healthy weight. These issues cut across so many different organizations that the place level is the one where you have a fighting chance of joining the things up.
yeah,
And that, I think, requires you to be quite, I mean, my hint and tip is that there is a science about working out who are the key organizations in your place who can have the biggest impact on these issues. And I'm happy to share it with people offline if they want to, but I have a system that I use where you try and map it and visualize it. And often people focus on what I call strategic power and influence, who sets the budgets, who sets the policies, who signs off the strategies. But actually, the other bit of the axis that's as important is the operational bit. And often that power is vested in people who are much closer to the front line. It's about teachers and district nurses and policemen and women and third sector organisations who in a local place have a much bigger influence and locus on what people do. And that role, the example of the third sector is a really good one for me, because often, people do trust councils generally, a bit more than they trust national government at times, but they probably trust a voluntary organisation a little bit more, especially an established one in the local area. And if you're looking for volunteers, then people are less likely to volunteer for the council because they pay the council tax. Why would I volunteer for the council than they would for a local charity? So I think, I would say be really clear about your relationships and put the hours in and put the time in and recognise and empathise, and that will help you empathise with those situations you will get into when NHS England is chasing them down for this or that new target or initiative, and they've got to play that game. They've got to do it, but they can do it in a way that doesn't cut across and disrupt what's happening locally.
Thank you very much, Tom. Jill, I'm going to try and give you the last word here, if the connection holds up.
Oh, sorry about that. I was just going to say that just sparked to my mind something that in one of the place-based work that we've been doing within the Kent footprint is actually trying to support an alliance of voluntary and community sector organisations in order that they're more able to kind of respond to the increasing demands, because some of them vary between being a 1 or 2 person organization to a 1,000 based organization, to try and get an alliance of them so that they can really have a big impact at place, and then supported by all the other parts of the system. And we actually did an event where we asked people to come into the room and to physically and metaphorically remove all their ID badges, so as they were just people in the room thinking about what is required in this neighbourhood to start looking at some of our issues. Really helpful.
Really good. Jill, thank you so much. Kit, do you want to just very quickly?
Yes, so just hopefully a helpful sort of follow on here. I think it's about having very few outcomes at a place level. So if you focus around, for example, healthy life expectancy, improving that, and then having a very smart narrative about how everybody's, if you like, process and activity measures contribute to that. So you can describe and see how everyone contributes to the overall statistic. And you have a very strong narrative of place that all the leaders buy into. So you might say the coordination for that is through the Health and Wellbeing Board. We haven't mentioned that, but that's where you can get some political air cover. That for me is the trick to get. So people are not seeing organisational priorities as in competition with place priorities. It's actually everybody's contributing, but you have to have a smart narrative.
Fantastic. Thank you so much. Thank you, Kate. Thank you, Jill. Thank you, Tom. Thank you, everybody, for joining us. I will write to everyone following up with a link to the report, a link to the recording of this. And Tom, people are already asking for your mapping exercise that I think you might have offered to share there. So if you want to share that with me, I can share it with people. But thank you so much, everyone. I really enjoyed that. I hope we learned a lot from it. I certainly did. Have really good rest of your day. Goodbye.